in this module on personalized healthcare and a focus on precision medicine, I would like to take this opportunity for this section to actually focus on another disorder, which is Parkinson's disease. So let's focus now on Parkinson as an example of how important it might be to implement a precision medicine approach and even wider, a personalized healthcare approach. So this is the classical image that we have of Parkinson. I think it's very important to talk about Parkinson because this is the fastest growing neurological disorder globally. However, when we think about Parkinson, what most of us have in mind is this picture. This was actually drawn by Sir William Gowers in 1886, and it represents a man, an older man, white, frail, in the typical position, right, hunched forward and shaking. And this is really the stereotype that we all have. And I'm sure you appreciate that there are millions of people affected by Parkinson in this world, and they definitely do not all look like this guy here. Actually, it looks more like this. So there is huge variability out there. And there is a movement in the Parkinson field to start appreciate and actually study this type of heterogeneity. So first of all, there is a huge range of symptoms, and motor symptoms, which are the ones we tend to think about, are just part of it. Of course, they're very obvious to see, but they're just part of it. They're not always there, not always in the same way and with the same onset and progression. And then on top of the motor symptoms, you have a bunch of non-motor symptoms, which are equally important for the patients. Sometimes some non-motor symptoms are actually more important for the patients and their families than the motor ones. And one very clear example in many neurological disorders, not just Parkinson's, are psychiatric symptoms. So when patients start to be paranoid or depressed, that actually has an effect on the patient and the families that sometimes is more disruptive on the patient and the families than a motor symptom, than the shaking. The other thing important to realize is that there is no one common path. So again, the progression of the disease, the way the first symptoms and then the way the symptoms progress is actually very personal, very individualized. It's very hard to predict how things will go. And actually, it's very important to highlight that is not, even though it's true that most patients are men, and of course it tends to come with older age, that does not mean that all patients are white old men. Actually, they are young and old, very important young onset Parkinson disease. Actually, this is a very interesting and important group of patients. They can be male and females, and this is something we will talk about. They can be still active, maintaining their activities, or debilitated. They can be still working. Some are retired, some are disabled, and with various symptoms and circumstances. So it is extremely heterogeneous. And instead of looking at this heterogeneity as a hindrance, as something that actually disturbs us, something that annoys us, I would like to propose to you the idea that this is actually a resource. This is something important and interesting that we should leverage to improve the solutions that we have, to make them tailored, to understand the disease first, and then to tailor solutions for specific groups of patients. So I am the co-founder and chief scientific officer of an organization called the Women's Brain Project, which studies sex and gender determinants to brain and mental health as the gateway to precision medicine. So I'm particularly interested in differences between men and women. And I think that this is a very nice and easy to grasp example of why we cannot assume that the disease is the same in every patient, that patients are all equal. Starting with the fact that male patients and female patients present differently and progress differently. There are a number of symptoms that have been described to differ between men and women, as you can see in this infographic. Very importantly, different response to treatment. It is known that women tend to have higher risk of dyskinesia while taking levodopa. And also very important is the effect of female hormones. So recently I had the pleasure to work with Rochelle Flanagan, who's a young onset Parkinson disease patient, also advocate and extremely interested in these sex and gender differences. So we have been looking into this topic together. And actually there is a huge literature documenting the fact, which is substantiated by the voice of the patients, the female patients, that actually when you have young onset Parkinson disease and you are a woman, so you might still have your cycle, or you might be entering menopause, this has a huge effect on the symptoms. So symptoms fluctuate during the month, and especially in the week before your period, symptoms will get worse. So it's actually known in the literature, and the patients that we had a chance to talk to, they all confirm that that is true. So they already know that 1 week per month, their symptoms will be worse. But there is actually no consideration of this. So their healthcare providers, their doctors are not aware of that. There is no conversation about these differences, and there is no adjustment of the treatment based on this very specific female need. And I think it would be absolutely wonderful and very important for the field if we could actually start a conversation about this and build enough evidence to have actually guidelines to tailor the treatment, for instance, for Parkinson patients, also based on these individual needs of men and women. And this is just one example. So I think Parkinson gives us an opportunity to talk about the importance of personalized healthcare of Parkinson and for neurology at large. So the idea of personalized healthcare is really that we should put the patient at the center, like Leonardo put the Vitruvian man at the center of the universe, and consider that this man should be the measure of, has some perfect proportions that are representative of the proportions in the universe and could be also used in architecture, for instance. The same way we should try and put the patient at the center of the healthcare process. Consider that patients are not all equal. We should consider this individual heterogeneity, and we should consider the specific needs and also expectations on patients and their family. So in the Parkinson case, is particularly clear that there might be outcomes, for instance, drug outcomes or treatment outcomes that are particularly important for patients, and maybe it might be more specific to symptoms that maybe they're not even the motor symptoms, and yet these are outcomes that are important for the patients and the families. And so I think patients, families, and drug development and healthcare providers in general should work together to really understand what is important for these patients and how we can provide them with a better treatment.